here. Thank you so much for the invite. I hope I can entertain you for about half an hour, and I'll try and stop. Then it's about transitions in cancer and the scale and profile, the incredible diversity we still see in cancer, and in trying to look at the future of cancer and how we can prevent and treat the disease. So there's really four parts to the presentation. The first two really are dealing with the problem and its scale and its profile. It's actually, I'm sure everyone is aware that cancer is increasing in terms of the number of new cases and the number of new deaths worldwide. It's not happening like that everywhere in the world, at least in terms of the rates, when we try and adjust for the age structure and the size of the population. But the sheer demographics of the world, population aging and growth, means that we're getting more and more cancer burden, more cancer cases, and more cancer deaths. But I'll try and look into that a little bit in terms of looking at the magnitude. But it's interesting to look at the complexity of cancer and different profiles of cancer we see regionally and according to levels of human development. And I'll talk about that, and we'll talk about the diversity and the inequalities too, and the really a requirement to have local planning, both in terms of the context of data, which is something that I, as has been stated, I'm particularly keen to promote and support, provide technical assistance to develop local data systems, subnationally, nationally, around the world, but also to promote cancer control across the continuum, particularly prevention and the sort of long-term realism that of an approach that requires not just treating the disease, but also looking at long-term strategies to prevent cancer in the first place. Okay, so a long preamble. These are some nice pictures from the bills of mortality. In essence, a tally of deaths from the 130 city parishes of London in middle of August 1665. This was the bills of mortality were provided every week following the bubonic plague at that time, 16th, 17th century. They were provided each week, just showing the tally of deaths. And this was at the time, the summer of 1665, where the Great Plague of London, so-called, was hitting. And I'm not sure you can read any of those. Apparently, the causes of death were quite ill-defined because of poorly educated coders and classifiers even then. But you can see that the major causes of death in the 460,000 inhabitants of London were, of course, infection pandemics. Was infection orientated, the plague, almost 4,000 deaths, fever, typhus, these types of disease, and cancer were only 2 deaths. So I'm not suggesting that this is a completely accurate portrait of the burden of the disease in the UK or London, but I'm suggesting that, of course, back in the 16th century, there were pandemics of malnutrition, infection that were the key drivers of morbidity and mortality, and a lot of deaths related to that. And of course, at that time, not so many non-communicable diseases. We've gone through a mortality transition. This is quite a famous paper from Omran in 1971 that termed transitions, an epidemiologic transition, a mortality transition, where we've gone from that time, 16th, 17th century, of age of, how he described it, pestilence and famine, to some breakthroughs, receding pandemics of infection and malnutrition through improvements in nutrition, hygiene, sanitation, and of course medical interventions that have increased life expectancy over the years in the 19th century. And as we move to the 20th century, we've gone to this time and this age of degenerative and man-made diseases, as Omran described. And that's in essence the non-communicable diseases that we often speak about now, the cardiovascular disease, cancer, obstructive pulmonary disease, diabetes, and so forth. But it's interesting to note, and I think it's sometimes called the late stage transition, or the last stage of the epidemiologic transition, that we are going to phase where some of the NCDs and some types of NCDs are becoming more chronic conditions, and there's a delayed mortality. And then with increasing life expectancy, there's a prospect that we can live with some non-communicable diseases, but at the same time there's the emergence and re-emergence of other diseases as well. So this is the phase we're in. If you look at cancer mortality at premature ages, less than 70, there are many countries, almost 50 countries, the most high-income countries, including New Zealand, where cancer is now a leading cause of death worldwide. It's transitioned in the last 20 to 30 years. Most of these countries, cardiovascular disease will have been the top killer, and it's been replaced by cancer. There's a whole set of countries that you could describe as transitioning to high-income countries where cardiovascular disease is still the top ranking disease, but cancer's coming through as second. There's a third to fourth ranking of cancer. There are other causes other than cardiovascular disease, but injury, intentional or unintentional, infection, maternal mortality, and so forth that have an impact. And particularly in sub-Saharan Africa, cancer sometimes is not in the top 5. It's certainly in the top 10, but there are many other competing causes. And this is a transition that's centuries old. Some of those transitions are actually only a few decades old, but the principle is that because of control of infection, and there's much diversity here, but because of control of infectious orientated diseases, NCDs and finally cancer will become the leading cause of premature mortality and probably the greatest barrier to increasing life expectancy worldwide certainly in this century. So that's perhaps bleak forecast, but there are things we can do, and that we need to do things now, of course, as urgent as possible to reduce the burden of cancer in the longer term. If you look at that map, it does actually, it could almost be a development map. And these are the quartiles of the Human Development Index. They're quite similar. This is an index by the UN Development Programme that tries to incorporate not just income, but life expectancy and education as well. So it's about how societies are progressing, as well as not just income, what do you actually spend your money on, and what impact it's having on education and health. So there's obviously a clear connection between the levels of societal and economic development and the types of disease linked to the epidemiologic transition. But variability there is, and you won't be able to see this, I think, because it's too small, but if you look at New Zealand and the major causes of death, you see that cancer is about 45% of the deaths, cardiovascular disease now about 20%, and then intentional injuries about 6%. It's similar in Switzerland and Japan, so countries far away from New Zealand, but levels of high income as well. 45% cancer, around 20% cardiovascular disease. These are the major causes. And if you go to a couple of the BRICS countries, say, countries that are emerging, big economies emerging, cardiovascular disease is number 1, cancer just behind it, commonly. Those two in China are some of the major contributors of premature mortality. And then in countries still in transition, such as South Africa and India, cancer's further down the line. South Africa still 45% is actually infection and parasitic diseases as the leading cause, whereas in India it's cardiovascular disease is number 1, but infection and parasitic disease is number 2, and cancer is number 5. So you get the idea. There's diversity, but it's linked also to transitions in human development as well. This is just looking at the trends in Japan. It's just interesting to see how many of these different diseases decline. That there has been successes in cancer control, particularly in high-income countries, but not to the extent of that we've seen for cardiovascular disease. So this is one of the reasons why cancer is becoming the number 1, because we've managed to control cardiovascular disease in particular, and that's become the the second leading cause, or even less. There was this transition in the early 1980s in Japan. So bear with me, this is going to move if you're lucky. This is just looking at the trends in the risk of death just in a 15-year period, 2000 to 2015, just for the major non-communicable diseases. On the left, and this is a product of the availability of mortality data, but on the left is countries with medium or high human development index. So these are countries in transition. They're not the lowest HDI countries, so we don't have mortality data largely for sub-Saharan Africa, alas, but so these are countries in transition. And then on the right are some of the high income countries, the highest income countries, the very high human development index. You can see New Zealand's in that picture, and so was Japan. So this is just to look at, so these are the rates, or the risk of dying, cumulative risk of dying. It sort of ranges between 10 and 35% in these countries in 2000. And we're just going to project this forward 15 years. And it's just to give the principal idea that there have been declines in non-communicable diseases, that there has been success. It's important to note that, but it's also important to partition out the different diseases. And I probably should have said I work for the International Agency for Research on Cancer. It's part of the World Health Organization, where we talk a lot within our organization about NCDs and control of NCDs, but you really do need to partition out into the different diseases. If you look at cancer, this is for 2000, you can see there's less variability than cardiovascular disease. Higher rates in some of the STANs, so-called former Soviet Union countries, Eastern Europe, but fairly stable elsewhere. Slightly higher rates in the very high HDI countries, because the rates are still potentially going up in some countries. But this is for cancer. Then you can see there have been improvements, fairly stable, but relatively modest improvements. It's only over a 15-year period. We can discuss the reasons for that. There are multiple: tobacco control, curative treatment for certain cancers. Less clear perhaps for the medium-high HDI countries, at least smaller, or perhaps even some cases more stable trends in mortality, but some success, but not as clear and as indicative as in very high HDI countries. So that was, I don't know if you can see that, but these are, I've just fixed the rates in 2015 for cancer, and let's just look and see what cardiovascular disease has done. So about that time on the, there's not a pointer, is there? No. Is there a pointer? And the mouse. This is the old style. So here you can see the blue is actually the cardiovascular disease, and the faint ones were the cancer. You can see that they've more or less in 2000, they're about the same, or their cardiovascular disease is already lower. In every case in the medium to high HDI countries, cardiovascular disease is much higher, a lot more variability. But when you look and track it over time, again, the progress is more for cardiovascular disease because there's some of the changes in risk factors that we've seen, such as tobacco, had a greater impact on cardiovascular disease, and of course, treatment and the prevention of mortality for cardiovascular disease as well. So that's a picture. Both are coming down, but non-communicable, in terms of overall profile of non-communicable diseases, there are bigger changes in cardiovascular disease, although there is some progress in cancer. But it's selected to these countries, so that we can't say what's happening in low HDI countries, where we know that, of course, mortality and cardiovascular disease is still increasing. Anyway, that was a long introduction. I think Professor Sarfati is going to be very worried that this is going to take longer than 30 minutes, and you all will be in time. So anyway, this is the Human Development Index. There has been progress in life expectancy, of course, in the expected years of schooling, and indeed in the gross national income per capita. So these are the dimensions of a long and healthy life, knowledge and health. There have been improvements in every country in the last 10, 15 years, more or less. There's been some countries, but a lot of variability, as you can see here, in this Human Development Index, and I won't dwell on this too much, but it's interesting to note that, and it does have an impact on cancer's profile. This is the burden of the disease. So we have about 14.1 million new cases in 2012. We have new estimates coming, and if I'd been doing this talk in July, I could actually show you 2018 estimates, but we're just finalizing them now. But in any case, 14.1 million new cases is what we estimate worldwide. You see Oceania is sort of highlighted, or the pie is exploding, so you can see it's about 1% of the overall burden. Mortality is about 8.2 million deaths, and people living with the disease, living within 5 years of a diagnosis, it's a much bigger number, 32.5 million. But the majority of cancer cases now occur within low and medium HDI settings, so there has been that transition as well. So many countries in transition are facing that increasing morbidity and mortality from cancer. And we can project, based on the demographic changes, which I'll speak to, and the changes in the risk, that there's probably going to be a doubling of the burden in the next 20 years or so. That's a projection, and one hopes it won't be the case, but just based on recent trends and as I say, population aging and growth, it does appear that may be the case. What's happened, of course, is it's part of this demographic transition that the fertility rates have come down quite rapidly from, in many countries in transition, very high rates of fertility to a much lower fertility because of, and with some time lag, a major decline in mortality. And part of it is having smaller family sizes, because parents realize they can actually have the size of family they would like, that will live to a longer age. So there's been massive changes in fertility, and of course with this epidemiologic transition, improvements in life expectancy and a lot of variability, as you can see here in different countries, partially linked to levels of human development. But what that's meant is there's been population growth, but particularly population aging, and cancer being a condition, of course, overall that's more common as you get older. That has an impact on the scale of the burden. So this is from 1950, just following through in the different levels of Human Development Index. Clearly the proportion of young ages, they're moving towards middle age. On average, the median age is getting greater in the four HDI, Human Development Index categories here. It's become very much like a tower now in the HDI countries. So there's been this big push from the young ages in 1950, still a relatively young population in low HDI countries, but that's still continuing. And the UN projections are suggesting potentially will be anything from 10 billion to 15 billion by 2100 as a population. And there's a lot of uncertainty to that, but a lot of the population aging and growth, particularly in countries in transition, has got many decades still to follow, and we will see an increasing burden, irrespective of how we manage to drive down the rates of cancer. So just based on the projections, based on just simply assuming the rates of cancer stay the same, we would expect about a 60% increase to 23 million cases by 2035. Just assuming that the demographic changes we see in every country as projected by the United Nations actually occurs. And of course, there's a lot of inequity in that because of the big changes in fertility. We're largely in the lowest HDI, medium HDI countries. Those with already limited resources to deal with the diseases of infection that's still quite prevalent. They have now facing the double burden of NCDs, and with these bigger populations, of course, we're going to see a bigger increase. So the low HDI countries are expecting the biggest increase in the number of cancer cases, and the smallest proportion in relative terms will be in the countries perhaps more equipped to deal with it, the highest income countries. And you can project that forward in terms of incidence, mortality, and prevalence, and you get big numbers don't know what's happened to that. But yeah, that's right. But anyway, that's the projections based on demography. It's not just, of course, the scale that's changing. Cancer is a complex disease, as we all know. It's at least 100 different types of disease with different natural histories, with different causes, and with different elements of prevention and curative treatment that we can introduce, some of which are effective and cost-effective, others are preserved of the highest income countries. But we ought to know what the scale and profile is in our communities to be able to deal with it effectively. This is just a global burden again, but just breaking out the major cancers. So lung cancer is clearly a key cancer, has been for many decades. It's the leading cause of incidence and mortality. Breast cancer just behind in terms of incidence, but prognosis is somewhat better on average, so it's a lower ranking of mortality. And cancer is associated with an infection predominantly, such as liver and stomach cancer, are very important sources of mortality. And colorectal is a cancer that's becoming more and more common, particularly in countries in transition. It's a marker in some sense of transitions related to many perhaps ill-defined factors related to nutrition and sedentary lifestyle and so forth. And then the prevalence, of course, is a number of persons surviving the disease, and it's a kind of a complex mix between the number of new cases, the probability of dying from the disease, and the natural history as well. But breast, prostate, colorectal are key drivers there. And this is just New Zealand, and it's a little bit different, but you can see prostate is number one, and that's, of course, part of that is induced by PSA testing. That's a very different disease from the traditional prostate cancer seen 30, 40 years ago when we didn't have PSA testing or other forms of testing. This is a disease that's micro-invasive and often leads to a great deal of incident cases, but a relatively small number of deaths. But anyway, that's just a profile in New Zealand. Still lung cancer number one, and colorectal is now number two, and breast is number three in terms of mortality and indeed incidence. So this is urbanization, and one thing that will happen is the more urbanization of low and medium HDI countries. That has many great things about it in terms of improved healthy lifestyle and sanitation and so forth, but it does engender, I think this will continue, the major changes in the built environment and pollution and many other factors that are not beneficial. So they will have an impact as well on the types of cancer, and particularly in the context of physical sedentary lifestyles, the extent to which they become more common as persons transit to urban dwellings, particularly in countries in transition, impact of obesity and so forth. Risky behavior, these sort of things are associated with urbanization as well. So this is part of the mix. When you look at specific trends in cancer, cancer really doesn't stay very stable, and they change all the time with the prevalence and distribution of the underlying risk factors and the extent to which interventions that are effective are introduced in the population. On the left here is cervical cancer. Just showing you some of the differences in the trends. This is going from 5 to 60. At the top, Uganda. This is the data from Kyodondo County. This is high-quality population-based registry data from a registry with 2 people and a shoestring budget, but it's incredible what they've managed to achieve. But there are some ups and downs related to the funding, but in any case, the cervical cancer incidence is extraordinarily high, and it's increasing among the population. It's the same in the other high-quality registry in Eastern Africa and Zimbabwe, in Harare. There's just the extent to which this is increasing is astonishing, and the extent to which the rates are so high. The rates are even higher than they were in Denmark, say in the 1950s, which had a a very high rate, at least in terms of globally back then. These are so that's a shocking rate and a shocking statistic, and you can see there's countries in transition where rates are actually coming down, and it's ill-defined as to why that might be, related perhaps to hygiene. There's not been specific implementation of programs in these countries, but rates have come down. And then there's others such as Denmark, Japan, US that have been hastened by, the declines have been hastened by organized programs. In the case of, certainly in Denmark, there's a bit of an increase in recent times in Japan, but I think it's going down. That's possibly a cohort effect linked to changes in sexual behavior as well. And then the US has had an opportunistic program, but there's been declines. Stomach cancer is another infection-orientated cancer, of course, and there's been some discussions on this today at the symposium, but you can see that despite Japan being a very high-income country, and we talk so much about infection-orientated diseases disappearing, stomach cancer linked very much to H. pylori is still very high. The extent to which the non-cardiac gastric cancers are still very common in Japan is very interesting. But there have been declines in many countries, and particularly in Europe and in the US, rates are actually quite low these days, and it doesn't fare in some countries in the top 10 anymore, where it used to be the first or second disease, and that's part of that unplanned primary prevention, linked potentially to H. pylori declines, but also improvements in diet and so forth. And colorectal, I've mentioned, is one of very complicated disease to try and understand. The dotted lines here are mortality, just to give you an indication, a signal that curative treatment has had a huge impact on colorectal cancer. But certainly in Japan, we saw a fourfold increase in 20 years in colorectal cancer between the 1970s and the 1990s, and it's stabilized subsequently, a very strong cohort effect linked to I guess, an underlying susceptibility and changes in lifestyle, including nutritional habits. Anyway, so this is, and Colombia is a country in transition. You can see very increasing rates of mortality, which is obviously a concern if there's no curative programs in place. Just from prostate and breast, and these big jumps you see here in the US are well known to many. This is when PSA testing became commercially available. And you can see the impact that has had on the incidence and mortality in US whites and blacks. And you can see these major increases are first with TERP and then the PSA testing, but you can see also a lot of curative treatment in terms of the mortality at about the same time. So it's a kind of combination of potentially PSA screening and radical prostatectomy, as well as curative treatment coming in as well. So it's a complex picture. And breast cancer, there's a bit of screening, but there's also, again, at the time that screening was brought in, more or less, there's been a series of interventions in terms of treatment that have improved the prognosis of breast cancer and driven down the mortality. But not in Japan and Colombia, where they did not bring in the interventions for different reasons. And just on thyroid cancer, yeah, this is a new one in the sense of relatively recently, the last 10 years, there's been a noted increase in the number of microinvasive papillary cancers of the thyroid. These are cancers that are found through ultrasonography, for example, and another relatively new treatment techniques, and it's led to quite a large concern of overdiagnosis of cancers, particularly in Korea, where this has been shown quite clearly that there's almost 80% are overdiagnosed cases, and the treatment is quite tough, the thyroidectomy and so forth. So it's a cause for concern. You can see the mortality at the bottom here is incredibly low. Again, indicating overdiagnosis. Anyway, cancer's complicated. The trends are changing. This could be a genetics map if you're interested in genetics. It's not. This is a ranking of cancer-specific rates. Just looking at, this is just the it's alphabetical order here of the different types of cancer, the main 27. The darker the color, the higher the Human Development Index. So these are 172 countries, just at the present time not ranked. But when you do a cluster analysis to try and really identify where the ranking of cancer is highest and linking that to the level of human development, you do see a sort of partitioning out of cancers. It won't be surprising to anyone, but there's this sort of principle that there's those cancers in the middle you see that are sort of more linked to affluence and westernization. These are the cancers you will see in the top 10 in the highest income countries. You will probably see it in New Zealand, I hope. The bottom, the infection and poverty related cancers, these are where the rankings highest among the low HDI countries. These are the cancers that one would like to think we're able to reduce, at least some of those. Cervical cancer through screening and the HPV vaccine, of course, Kaposi sarcoma through antiretroviral therapy, changes in the prevalence of HIV, AIDS and so forth, liver cancer through the hepatitis B vaccine, etc. But the principle is there's a different set of cancers that are emerging as we move forward, as well as the increasing scale as we begin to transition away from infection-orientated diseases. Within cancer, we have this cancer transition, and we're moving towards those cancers in the middle as we begin to reduce some of the infection and poverty-related cancers. That's a very simple way to describe it. And those top cancers there, the residual mixed, they're a combination of factors because the risk factors are different in different parts of the world, not necessarily linked to human development. But when you look at the proportion of those three types of cancers, if that's a group, you can see it's quite clear that in terms of the proportion of cancers, the blue ones here, the affluence and westernization ones, are a very big part of it, and of course the infection and poverty ones are still very high in the low HDI countries. So again, a transitional thing. And this is where we got the projections from. So you can make some assumptions about the trends that you see in low, medium, high, and very high HDI countries, and then assume that as they transition, they will also not only have the demographic projections, but they will take on the trends as well. So there's a risk component here as well. I'm not going to go into any great depth, but this is just showing you for overall. We did this for levels of human development, but the idea is that, okay, stomach, so towards the left of the zero, you see here at the top, these are declines predominantly in different registry populations. So we use the registry data, and towards the right, there's actual increases. It's back of the envelope calculation in a way, over and above demographics, but it does indicate that, okay, you have the demographic change, but just looking at the major trends, if they were to be taken on by all the countries within the level of human development, we would have an additional 40% over and above the 60% increase in just due to demographics, and that's where you get the 29 million. So that's, you might argue that's not the best way to do it, but we're trying to develop it a little bit more sophisticated than that. But it's the general principle is a lot of it's related to demographics, and that there's probably changes in risk that will increase the burden in the next 20 years. And you can make the projections to mortality and prevalence as well if you like. There are deviations. I spoke about Uganda and Zimbabwe. I mean, we are facing a double burden of both infection-orientated cancers and more Western-orientated cancers, so-called, in countries in transition. I've mentioned the very high rates of cervical cancer. Data's a bit strange in some places, but for example, in Kampala, you can see the increases in breast cancer. Prostate cancer has always been really quite high, and cervical cancer I've mentioned is very high. Kaposi is coming down, at least in men, but rather stable in women, actually in Zimbabwe. But we note these trends, and it's a complicated picture indeed. But we see the transitions. This is the data from Colombia, the Cali registry, just looking at sort of 50 years of data. There's been a big transition in the sense of some new cancers coming up. Colorectal cancer, I think, was 12th in the 1960s. Now it's number 3. But still, breast and cervix are the major causes of cancer. Stomach cancer has only moved down from the 3rd leading cause of cancer to 4th. Thyroid's come up, lungs come up. But a complex picture, which has some of the old aspects of infection-related, poverty-related cancers, but also new cancers emerging as well. These are the trends in cervical cancer in some of the countries in Eastern Europe and the Baltic countries, in at least Estonia and Latvia, and Lithuania and Belarus, former Soviet Union countries in Eastern Europe. On the right is Bulgaria and Russian Federation, and these are trends in cervical cancer incidence as well. So these are countries, very high HDI countries, really that show the diversity, and there's not a single picture that can explain everything. So these are countries predominantly with very limited organized screening programs put in place in the countries. And this is the case for Belarus, a very strong cohort effect. So it changes in sexual behavior, more and more infection with high risk HPV types, leading to this increase in successive generations in cervical cancer. And in the absence of screening programs, cytological programs that are effective, and you do not drive down the cohort-specific rates, and both the incidence and mortality increases. This is just looking at some data in India. I've highlighted Barsha. This is very much a rural registry, actually of quite high quality in Maharashtra region of where Mumbai is, and the other registries are all very much urban registries. And a marker of transition is seeing these increases in breast cancer and declines in cervix cancer that happen at different times. But you see in Barshi, the very rural population, actually they're pretty much parallel with cervical cancer, still much higher than breast cancer. So this is interesting to note, and I've shown this already today. The work that we've done with some of the collaborators, just trying to show the importance of the differences in indigenous communities versus their non-indigenous counterparts in using different registry populations in the US, Canada, Australia, and here in New Zealand. And you can see, I hope, the extent to which lung cancer, despite these being high-income countries, is much worse in terms of the rates in the indigenous communities relative to the non-indigenous counterparts, and similar for cervical cancer. So these are, again, indicating the importance of looking at data locally, but also looking at data in subpopulations where targeted interventions could have an impact. Okay, so this is my last piece, you'll be pleased to know. Just about action across the cancer continuum. So data is really important to be able to advocate, to be able to plan, to be able to implement, to monitor, to change your programs if they're not successful, to show your work, and etc. There's a lot of requirements for better global data across the cancer continuum. Really, we need basic surveillance data, we need risk factor data, we need incidence mortality data at the local level worldwide. We need to expand the measures of cancer surveillance to support cancer control actions, and we need to demonstrate the success, particularly of prevention, and it needs a long-term vision to do that. This is the availability, slightly old statistics, a few years old, but it gets to the point of where you see that only 1 in 3 countries, predominantly high-income countries, have high-quality cancer incidence data, and only 1 in 5 countries report to WHO relatively high quality mortality data. So it's not an ideal picture when we're trying to understand how cancer is changing. We're making a lot of guesses in our estimates, and we'd like to know much more about the local profile to support cancer planning. I'm not going to talk about this today, but we do have a global initiative called the GICR, Global Initiative for Cancer Registry Development, with a plan as a partnership, a coalition of the willing, and development of regional hubs and developing priority countries whereby we can actually support the development of cancer registries. And we pledge to try and develop 50 population-based cancer registries of high quality by 2025. It's a bit of a tough target to make, but we're looking for global funding from the philanthropics and others to try and make this happen. But we believe we can. It's very important to us. This is some of our colleagues in the early 1970s in Lyon in France, Colombia, and Dr. Chulinius. Chulinius was the director of the Icelandic Cancer Registry in Colombia, passed away too early. He's also someone from Scotland who led the unit of descriptive epidemiology, which turned into our section. But the provision then, and it's the same now, is we want to have good quality estimates nationally of the cancer burden using high quality data. We'll validate it against high quality data, particularly from cancer registries. And with that, we can support in-country investments in data collection. So we get better global estimates, but we also get robust data that governments, that health planners can actually use to develop cancer control strategies. It's those two things. We're not just interested in the data per se, we want to actually support the systems in countries. And we believe population-based cancer registries, particularly where civil and vital registration systems are still inadequate or non-existent, are an incredibly important resource and are usually feasible to implement. So we try and do that and then provide the estimates where we can in what we call our Global Cancer Observatory, which is still under transition. So the bottom line is we have this cancer control continuum. We study different populations. We consider cancer registries to be integral in developing incidence and survival data, but very much complementary to the activities in relation to collecting risk factor information and mortality data, ideally from vital statistics, but other methods are required. And we can extend those measures when we have that information to look at other key indicators of health and of the cancer burden, and try and attach an economic argument to them as well. So lastly, I mean, the economic argument for premature mortality from cancer is really quite important. This is just looking at the BRICS countries and Europe, and there's a couple of studies we did recently just showing the proportion of GDP that premature mortality from cancer actually causes. So dying from cancer early before pensionable age, what is the impact on productivity? But the numbers are big. I mean, it's 46 billion in the BRICS countries alone in 2012 lost because of premature mortality and death in the workforce, and a large figure in Europe. And these are the cancers, predominant cancers. So it again links back to the importance of tobacco control, of vaccines, of screening and prevention and early detection, and actually reducing the premature mortality, but also improving the economic productivity of countries as well, particularly in transition. So there's an argument there. Our director, Christopher Wilde, he said this many times, and it's something that I think many people have taken on now, that no country can afford to treat its way out of the cancer problem. It's absolutely fundamental to have effective cancer care, but we need a balanced and integrated approach to cancer control that embeds prevention and early detection into programs. We have had a decade of action. This is more from a WHO perspective, I guess, in terms of a lot of commitments, high-level commitments by governments to tackle NCDs, a roadmap of commitments to to try and prevent, control NCDs, and then including that a series of global targets and indicators that should be accomplished by 2025. The Global Action Plan does indeed include 9 voluntary global targets, really with a view to doing this 25 by 25 target, realizing this target rather, 25% reduction in premature mortality from NCDs through these six targets in terms of risk factor changes, so a halting of diabetes, obesity, reduction in 25% of raised blood pressure, 30% reduction in tobacco use, 30% reduction in salt, 10% reduction in physical inactivity, and a 10% reduction in harmful use of alcohol. So these are the six targets for a reduction in premature mortality, and that there has been work to show what impact that would have worldwide and indeed regionally if those 6 risk factors you were able to sort of meet the targets. You would get a 10% reduction in harmful alcohol use, 30% reduction in tobacco. And the good news is that, I don't know if you can see this, but in both men and women, particularly in men, you're more than likely to meet the target based on the global data that's available, particularly if there's a more invigorated approach to reduction of tobacco control. So not 30%, but 50%. But anyway, the targets are being met globally, not necessarily regionally, but that's another matter. But the point I would make here is, okay, so you see a 21% reduction overall. It's only a 7% reduction by 2025 in cancer, despite the projection being that it's going to be 40% of the NCD burden by 2025, and the risk factor contribution is relatively small. So it reiterates the complexity of cancer. The natural history of the disease is long. Preventive actions are going to take much longer than by 2025, and they're not necessarily the right risk factors for a given community, and there are other interventions. Clearly, tobacco use is a clear one. It's part of the Global Action Plan. There's a special Appendix 3 that goes through all the best buys, and particularly increasing excise duty on and prices on tobacco products does indeed work. The studies have shown that price hikes in France and South Africa in the early 1990s had a huge impact in reducing the consumption of cigarettes. And you know, that's been shown in many different places. That is a key measure to reduce tobacco. And you don't need the incidence and mortality data. I mean, that will follow in with a given lag. In the US, it's been shown you can project what the rates would have been if there hadn't been this decline or cessation of tobacco, as well as reduction in the uptake of tobacco in men and women. And you can project how many deaths have been avoided, a very substantial number indeed, by the community not deciding not to smoke or giving up in time. So this is obviously a key element that embraces all NCDs, or many NCDs, as well as cancer, to have proper tobacco control. And it talks, of course, very much within this action plan of the invigorating the framework for the control of tobacco. But of course, the specific interventions that we do locally, nationally, or regionally will be very, very much dependent on the particular types of cancer. And it's worthy of note that still in parts of sub-Saharan Africa, the burden of cancers related to infection is still very high. 1 in 3 cancers in some countries are related to infection, Kaposi's sarcoma, liver, cervical cancer. And on the other side, with the impact of obesity and other nutritional correlates on cancer, we're now seeing an increasing impact of high BMI, overweight and obesity on cancer as well. And that's at the moment impacting on the highest income countries. So just on this is just 3.6% of new cancer cases in adults are attributable to a high BMI. bigger in women because of the particularly the impact of obesity on postmenopausal breast cancer and endometrial cancer. But the idea is you can look at the preventability of cancer in terms of overweight and obesity. There's different scenarios you might put together here on the left, whether you maintain a healthy BMI, you go back in time to the lowest that was ever achieved in a given region, back to a certain BMI level in 1982, or a unit decrease in BMI, and just looking at the impact that this might have in cancer. And it is quite substantive. You can prevent quite a lot of the burden of cancer now we see related to obesity if we are able to put in these interventions. And the specific interventions, of course, are going to be more effective depending on where you are in the world and the level of obesity that currently exists. Anyway, with cancer, generally we have a number of best buys and other recommended interventions now that are very clearly stated. The HPV vaccine has been shown to be cost-effective. Prevention of cervical cancer by screening, resource-dependent methods, but that's again been shown to be a best buy. And there are others where that are perhaps less cost-effective, but are effective interventions: mammographic screening, treatment of early-stage colorectal cancer, and others that haven't been evaluated, such as yet prevention of liver cancer through hepatitis B immunization among neonates, for example. So we know the specific interventions that can have an impact on reducing the burden. This is just showing the impact. I mentioned Belarus and the Russian Federation. If they were able to implement an effective screening program, as we've seen in the Nordic countries, then we would really be talking about a major reduction in the projected rates that we see. So and these numbers are quite substantial. In Russia, if we were able to prevent, if we were able to implement screening in 2017, by 2040, we'd be able to reduce the number of cervical cancer cases by 150,000 in the cumulative years. So these are big numbers. So we try and put together this evidence base of the importance of prevention in the longer haul. And this lastly is the vaccine for HPV. And of course, it's going to take 40 years to reduce the cervical cancer burden by half with the vaccine. So again, it'll take a long time to have its biggest impact, but we should see a 70% reduction in the cervical cancer burden worldwide by 2070 if there was adequate coverage and implementation of vaccine. And this is work with Kate Sims and Karen Canfell, just trying to quantify the impact of the combined initiatives of vaccine with the non-valent vaccine plus a 2 times lifetime screening, and the prospects that could reduce the cervical cancer burden and could prevent somewhere in the order of 7 to 9 million cervical cancer cases over the next half century if the coverage was high with vaccine and there was provision for screening too. Okay, so there is a high-level political focus. There are UN Sustainable Development Goals that now include cancer, with this 30% reduction in NCDs by 2030. And we have now a cancer resolution that links to the Sustainable Development Goals and the action plans. There's a lot of discussions about development assistance and innovative finance models that mean that there'll be more money going from infection-orientated diseases to NCDs over time. And there is, of course, an increasing commitment to cancer control among high-level leaders, members of different governments worldwide. Okay, so I don't really have a conclusion side. I've just realized, but I think I'll stop there anyway. This is more or less what I said. Thank you very much.